I'm going to start. It's fantastic to see so many people joining us for this latest in a series of health inequality summits. Today's summit is the deep end of primary care. My name's Dave Julian. I'm the chair of the Deep End Network in North East and North Cumbria. And my job today is simply to keep things to time. Couple of matters of housekeeping for people. Please do keep your cameras and microphones turned off throughout the course of the day. We will be inviting you to interact with us, and there's two ways that you can do that. One is via the Slido questionnaire, which is a link in the chat box. So if you go into the chat function, there is a Slido link, and if you join that, that will take you to a questionnaire that opens up in a different window. And questions will be appearing throughout the course of the day on the slides of the speakers. And please do fill in that Slido questionnaire. We're really interested to find out a bit more about who you are and where you're from. The second bit is we're also going to be inviting you to a question and answer session, which is going to be later on in the day at just after 1:30. And we will be inviting you to share questions in the chat function. You can ask a particular speaker a question, so please do indicate that, or you can ask just a general question that we will put to the panel. So, without further ado, we're going to kick things off. I'd like to welcome Dr. Guy Pilkington to lead us off. Over to you, Guy.
Good afternoon, everybody. I don't know quite what you can see at the moment. I hope you can see the slide, but isn't quite moving on at the minute. Is that not? Why is the slides not moving, I wonder?
I'll move you. I've moved you, Guy.
I've
moved you.
It's moved. Yeah. Oh, you did you? Okay.
I did, but yeah.
So thanks for the introduction, Dave. I'm also a Deep End GP in North East North Cumbria and sit on the steering committee that Dave chairs. And thank you so much for coming. I think we're up over 250 people in attendance already, and I think that just is testament to how important the agenda for this summit is, which is how do we think about the difficult challenge of making a contribution to tackling inequalities as we see them in our communities from the position of primary care. And the Deep End Network, you'll hear in great detail from the speakers that are coming about how we intend to work and how we are working in North East North Cumbria. So my role is to just welcome you all and to introduce you to some of the concepts and also to take the opportunity as a Deep End GP who has worked in the Deep End. I work in Crudders Park in Newcastle upon Tyne for 33 years now, to pontificate and reflect on some of the experiences and some of the things that I think I've learned through my career. So if we look at Oh yes, moved on. So some reflections on 33 years down the deep end. And I'm going to talk a little bit about why I think general practice matters, why the inequalities that we're here to consider clearly matter, and why you as an individual and as an organisation are really important to what the NHS can do. So general practice. I went back to have a look at a paper that Iona Heath produced back in 1995, The Mystery of General Practice. It was written at a time when fund holding was starting, when the concept of the internal market was relatively new, brought in by the Thatcher government and so on. So it wasn't a particularly easy time for general practice, but I really liked what she described in her paper, The Mystery of General Practice. And she talked very eloquently about how, as a GP, we act as interpreter and a guardian at the interface between illness and disease. Our patients experience diseases, but more importantly, they have illness experience. And that illness experience sometimes may be rooted in disease, sometimes may be rooted in all other things that are going on in their lives and so on. So the interpreter is a function that she thought was really important, but also she talked about how being a guardian meant that we were responsible for not only ensuring that an individual with an illness experience gets good care and treatment, but also that we protect them from unnecessary medicalization of what may not be medical disease. And then she also talked about how a really important function for the general practitioner is to be the witness to that patient's illness experience, not just once or twice, but throughout their enduring experience. So for me, some of my patients, I've witnessed their illness experience over 33 years, and I think that in itself is of some importance within that. And there is a lot of debate currently about continuity and the gift of continuity that we have in our profession in general practice, and actually how some of the trends in the transformation of how general practice functions, there is some risk to that continuity. And recently the all-party parliamentary group was talking about the importance of continuity and so on. Finally, I think in general practice, and maybe we don't spend enough time thinking about that, within our neighbourhoods, we are anchor institutions. We're really important places for communities on our doorstep. And I think we can usefully spend time thinking about how we are a community function and a community place within the neighbourhoods in which we work. The inequalities, I'm not going to spend any time really on this. This is what the next couple of hours is going to be describing and talking about in much more detail. But we all know that everything within the biopsychosocial sphere is on a gradient, and that gradient very much runs with affluence and deprivation. And many of you will have seen and read lots from Michael Marmot and his team, but he described how if the needs of our community are on a gradient, what we need to do is we need to think about universal responses and universal services, but we have to accept that these also have to be on a gradient, resourced on a gradient, so that the universal responses are appropriate to the needs of the community that we face. And I think a lot of what the Deep End Network is about thinking about how you get those resources to match the needs of the communities in better ways. And then finally, I think it's really important, and I hope we all agree with this, that the NHS is very much an example of a social justice institution, and that we not only have a duty to deliver good medicine and good care, but we are actually involved in a response to the social inequity that we are facing. So finally, this is my last slide. Why are we all individually important in making a contribution to our responses? It's difficult. It's difficult to practice good medicine at the deep end, but we have a duty to do our absolute best with the resources that we have available. And not only is it about providing the best medicine, the medical interventions for the diseases that were prevalent, more prevalent in the deep end than elsewhere, but also about providing the best care possible. I want to finish by quoting Julian Tudor Hart, who has been an inspiration to most of us who work in the deep end. And he talked about how the consultation, the epicenter of what we do in general practice, is an opportunity for the co-production of health, and that in that consultation, critical decisions are being taken all the time. And the quote here says, "The quality of consultations must in large part depend on freedom from time pressures without perverse incentives to save time by ill-considered somatization, prescription or referral, and with protected time in which to develop the patient's capacities as producers rather than consumers of their own health." And I think that's a great quote. I think it sums out so much about what is important about what we do on a daily basis within general practice. And within that, the relationships that we have, not only with our patients, but with our colleagues, is critical. So I hope we're going to have a fantastic afternoon, learn a lot, hear a lot, and be inspired a lot. And I hope you enjoy it.
Brilliant. Thank you, Guy, and perfect timing. No pressure for the rest of the speakers, but Guy nailed it there and came on a sixpence, so well done. Just a couple of items of housekeeping again, just reminding people to keep your microphones and your cameras turned off, please. There is a link for a Slido questionnaire that's in the chat, and do put questions for our speakers in the chat as well, which we will curate and put forward in a question and answer. Anyway, I'm going to hand on now, with no further ado, to Edward Kanunga, Director of Population Health Management at NEX, Population and a Public Health Consultant. Edward, over to you.
Thanks, Dave, and good afternoon, colleagues. I think Guy has already summed up the key issues with regards to inequalities in primary care, and why it is important for us to do all we can in terms of addressing these inequalities, but also how resource allocations need to be able to create an environment that supports all of the efforts that colleagues in primary care are already doing. So I just thought we'll probably start off with just going back to basics. This is kind of public health or health systems 101, which is about understanding the relationship that exists between a need, which is the ability to benefit from interventions, with demand, which can either be expressed demand or in many cases unfelt or unexpressed demand, and how that relates to supply. And if we had more time, we would have talked through some of the different overlaps between those areas. But I guess the main point is that we need to make sure that there is a good balance between understanding the need, understanding demand, and making sure that the supply matches that. And I think whenever you see significant challenges within the systems, it usually is a reflection of those three circles not aligning, usually that the need is greater than the supply that's available, or in some cases, the expressed demand is overwhelming the system. And we'll refer back to this when we talk about resource allocations, because supply is pretty much resource dependent. So inequalities are very much at the center of NHS policy. We have seen an increase in the explicit reference to inequalities within NHS policy, especially during the pandemic. And as we are coming out of the pandemic, a very explicit reference to inequalities. And I won't steal my colleague Becky James's thunder, because her presentation will talk a lot more about the core themes for action and what you can do either at a practice level or at a PCN level to embed inequalities in the work you are already doing. One of the national programs that you have had or will continue to hear a lot more about is the Core 20+5 program. So this is the national program headed by Dr. Bola Olabi, the Director for Healthcare Inequalities in NHS England. And essentially, it talks about trying to combine geographic inequalities or inequalities associated with deprivation or where you live, or IMD scores, Index of Multiple Deprivation, with also a recognition that there are some vulnerable communities whose health outcomes are poorer than others, and then focusing on the 5 clinical conditions. So the Core 20 stands for focusing on the 20% most deprived communities nationally. And we know certainly up here in the Northeast and North Cumbria, there is an over-representation of our populations who live in the 20% most deprived areas. We estimate it's about a third, so 1 in every 3 people live in these areas of that qualify in the 20% most deprived. And in some areas, it is as high as 1 in 2. The plus groups are the inclusion groups. So these are patient groups that we know don't always get equitable access, good experience, and also experience poor outcomes. So people with substance misuse issues, people who are homeless, gypsy, Roma, and travelers, asylum seekers, all of those are communities and population groups we need to focus on. And then the 5 clinical conditions are making sure that we make the improvements within the maternity care pathways, people with severe mental illness, improving the quality of care in respiratory, chronic respiratory disease, early cancer diagnosis, and hypertension. So this just outlines the scale of the challenge really for us here in Northeast and North Cumbria. So you can see there's an overrepresentation of our population in the most deprived areas. And very clearly the deep-end practices look after quite a significant part of our population that resides in areas of most deprivation. So I'm sure you will hear a lot more about how the deep-end program is interfacing with the Core 20+5 program. But what is also interesting is no matter where you look in terms of health outcomes or demand for services, there is a consistent disproportionate overrepresentation of people from the most deprived areas. And in essence, those patients will be under the care of deep-end practices, which highlights a number of issues. So this is our elective recovery program. So we know 52% of patients whose surgery has been deferred as a result of the pandemic live in the 20% most deprived areas. When you look at the clinical burden of multiple long-term conditions, significantly higher than the rest of the population. So not only are these patients waiting for surgery, they also have a number of other significant underlying long-term conditions, which require constant and continuous support whilst they are waiting for surgery, and in effect might have a negative impact in terms of surgical outcomes. So the Preparing Well program is an attempt to really identify those patients and support them. Then in terms of people with learning disabilities, again, we have done a bit of profiling of what do we know about that population. Again, comes as no surprise. You can see significant proportion of the population residing in areas of multiple deprivation. So within, again, that core 20. So not only do these patients have severe mental illness, but also they are living in areas of deprivation. So just to quickly talk about supply issues, there is work that has been done by colleagues from the York Health Economics unit looking at the cost of inequalities. And this is where you get the £5 billion cost of inequalities that people often refer to. So this is looking at elective hospital episodes, emergency hospital episodes by the deprivation quintile. And you can see how that increases for the most deprived areas and how the gradient is much, much sharper for emergency care. When you then put pound signs to that and you use your most affluent areas as your benchmark, you can see the cost of looking after patients in the most deprived quintile is £2.1 billion more when you compare that with people from the most affluent areas. So this is one of the factors that then drives the issues with regards to supply and resource allocations need to reflect that level. And sadly, the resource allocation formulas we have don't go far enough in reflecting that. These two graphs worked by Ben Barr and colleagues highlight that whilst there has been an increase in the amount of spend per head in deprived areas, there's also been an increase in affluent areas. So the absolute difference and the relative difference continues to be a challenge. And if we are to implement the proportionate universalism that Guy talked about, then we need to make sure that resources are shifted to reflect the level of need. And the scatter graph to the right there shows a very clear association between areas where there is significant improvement in changes and a reduction in mortality that is amenable to healthcare. So it is very clearly set out that more investment will result in improvements in outcomes and will prevent deaths. The Tackling the Inverse Care Law is a report that I would recommend. Sorry, I've lost my slides, but I'll wrap up. It's a report that I would recommend for people to read.
You have 5 minutes left yet, Edward. Not quite sure what's happened to your slides, so please don't rush.
No problem. So the Tackling Inverse Care Law report by the Health Foundation looks back over the last 10 years and beyond, and looks at the trends in terms of primary care resource allocations, in terms of the workforce within primary care. And whilst it acknowledges some improvements, it still highlights that there has been significant gaps in between the most affluent and the most deprived areas. And I think that's one of the challenges that report finds out. And I'll just demonstrate that with one of the slides. Yeah, so you can see there the trends that they have observed in terms of GP supply per 100,000 by neighborhoods deprivation. And you can see there that the pattern has followed the same trend. And if we are to see that proportionate universalism that Mamo talks about, we need to be seeing faster growth in the deprived areas. And we need to be seeing the GP practice payments reflect the level of deprivation and the amount of work that is required to support patients who often have complex social and multiple vulnerabilities and multimorbidities. So that report summarizes the progress so far by saying the inverse care law still persists within the NHS. Most deprived areas are still underfunded, they are still underdoctored, and there has not been significant focus in terms of addressing this issue going forward. And that whilst there is the government's ambition of levelling up agenda, it needs to take into account levelling up in health resource allocations. And that general practice is the foundation of the NHS and is very well placed to tackle health inequalities, but it requires the appropriate levels of resources to achieve that. So I'll finish off with some of the work that we have been doing in terms of resource allocations. And you might question why a public health talk ends up with a very big cake. Well, it's a healthy cake. But the analogy that we have been talking about is, if you think about the resource that comes into the region as a cake, the national allocation formulas that decide the size of the cake for our region do not go far enough to reflect the complexities and the level of health resource utilizations. Then there is how we cut the cake when it arrives in the region. And I think there is an opportunity with the ICBs for us to do things differently in terms of how do we allocate resources and ensure that those resources are targeted to areas which will have not only the biggest impact, but that will have a big population coverage. And then what do we do with the accessories, so the icing, and from time to time we get additional investments that come in. This year we've got the health inequalities funding. There will be other investments. How do we make sure that we are targeting those resources to areas that would benefit the most? So hopefully that's given you a good overview in terms of the challenge that we face and the need for us to collectively use the information and the data that we have to reflect the burden of disease in our populations, how it is disproportionately reflected in health resource utilization, and how that should inform the resource allocations at a national level within our ICB and also within PCNs. So I'll stop there and I'll be happy to come back and answer any questions.
Thank you, Edward. As always, a fantastic presentation with lots in there. Didn't even miss a step when your slides disappeared. Consummate professional. Thank you. People, please do post questions for Edward in the chat box, and we will bring those back up when we do the question and answer later on this afternoon. I'm going to now move on to introduce Sarah Sowden and Samina Hassan from the DPEN Network steering group. Sarah is our research lead and Samina is our co-clinical lead. Over to you. Thank you.
Thanks very much, Dave. So yeah, my name is Samina. I'm a GP in Gateshead and I'm the co-clinical lead of the DPEN GP network in North East and North Cumbria.
I'm Sarah Sowden. I'm a clinical lecturer at Newcastle University and I'm a public health consultant in the Office for Health Improvement and Disparities in the North East and North Cumbria. And as Dave says, I lead for research for our DPEN network.
So our Slido question is, what are your health inequality priorities? So please use the link and we're really keen to hear what you are prioritising in your area and your job. So I thought I would just start by reflecting a little bit about why I came into the DPEN network and how I got involved in it. And when I reflected on this, I thought about my GP placements throughout my career pathway. So initially in medical school in Edinburgh, I was placed in areas where there was pocket deprivation, which let me understand the differences between different patient journeys. And then as an F2 in my foundation training program, I was placed in a GP practice, which covered areas like biker, again, looking at those kind of differences in people's pathways and journeys. And now knowing that what I was looking at and noticing were the wider social determinants of health. And then during my vocational training scheme, I was placed in an ex-mining village in North Durham, which happens to be very similar to where I've ended up now for the last 7 years, although it was slightly more affluent. Now I'm in Gateshead in a small semi-rural practice, which is also an ex-mining village. And I think it was really important for me to look at that and think about that, because as Edward said, I think these exposures to health inequalities and understanding the differences in patients' journey has led me to where I am today and can help other people look at where they want to be. So we've already talked about this quite a lot, the inverse care law. Why is it called the deep end? Guy and Edward have both talked about the inverse care law, and I'm sure everybody here knows quite a lot about it already. But this is a core value of the DPEN GP network, and it was coined by Julian Tudor Hart, where he basically looked at the resource and demonstrated it in this illustration of the swimming pool effect, where the surface is the resource and the need is the depth. And you can see that the people who were living in areas of high deprivation had the greatest need and were literally drowning in the swimming pool. And it's not a level playing field. With over 15 years of research showing that people living in these areas of high socioeconomic deprivation often have multiple long-term conditions at a younger age and therefore live with ill health for a longer period of time and die younger than their more affluent counterparts. So the DPEN GP network was originated in Scotland by the DPEN group in Scotland, where Professor Graham Watt described his challenges with GPs working in areas of blanket deprivation. And he essentially flipped that deep end swimming pool and made the flag motif, which gave a sense of community to the practitioners working in areas of high deprivation and a movement and a community and a voice to those practices. And it has now become a national and international network with DPEN groups across the country and across the globe, all looking to tackle the inverse care law and the way in which primary care is funded. And so what did we do with our DPEN network in North East and North Cumbria? It started in 2020 with the key aim to tackle the inverse care law, a partnership between local GPs, public health consultants, research colleagues in the National Institute of Health Research and the Applied Research Collaboration, NHSE and our North East Commissioning Support Unit, with financial and business intelligence support from our ICS. And our aim as well to collaborate, create positive change for our practices, give them an area that they could be supported and share learning. And so who are our practices? We use the same formula that the Scottish Deep End Network have used to identify practices working in areas of blanket deprivation, with looking at the proportion of their population who lived in the most deprived, 15% indices of multiple deprivation data zones. And out of all of those practices, we found that there were 38 deep end practices in the North East and North Cumbria ICS.
So why do we need the deep end movement? We've heard quite a lot of the data from Edward, and now I'm going to just give a bit of a perspective from the research perspective on our deep end network. So researching the deep end in the North East and North Cumbria has really been there since its inception. The North East and North Cumbria Applied Research Collaboration, the Marginalised Communities and Inequalities theme, has been round the table from the get-go. And that's been really important for our evolution of our network, because it's enabled all of our network decision making and activity to be based on evidence of what's known already, but crucially add to the evidence base of what works to address health and healthcare inequalities in areas of severe and extreme socioeconomic deprivation. So our deep end research activity is broad. There's lots of different elements to it, supporting all of the different work programmes within deep end. So we have co-created the deep end network. We have undertaken research looking at COVID-19 and done some really important work looking at the impact and insights into how it is in deep end practices during the pandemic. We are now busy evaluating several of the pilot interventions that deep end is now supporting. We've had research activity supporting understanding workforce recruitment and retention issues. And then there are specific projects that link into our deep end around specific clinical areas. For example, a piece of work being undertaken by the ARC and the HSN around lipid management also has a focus on deep end. And we've been working with our partners in NEXT, the North East Commissioning Support Service, around barriers and facilitators to engaging deep end patients and practitioners in research. And indeed, we've got a very active and emerging patient and public engagement and involvement programme of activity in our deep end network. So, as I mentioned, we're going to talk a little bit more about the co-design work that we undertook. So in this work, we conducted semi-structured interviews with practitioners working in our deep end in what was really the second wave of the COVID pandemic. That's when we were undertaking this research. So we interviewed 11 GPs, 2 social prescribing link workers and 2 nurses. Their careers in the deep end spanned from 3 months to 31 years. So there's a very wide breadth and depth of experience. We conducted semi-structured interviews with these individuals and thematic content analysis with a very much a social determinants of health lens of focus for our inquiry, given the context and the history of the deep end movement. So we undertook this research with the aim of understanding the challenges and really why is a deep end network needed in our area, and also what a deep end network could offer. And as I say, because these interviews were undertaken just when it happened to be a pandemic, it also enabled us to get a really good sense of what that experience was in the deep end at that time. And I think this quote just exemplifies a lot of what we can see in data and charts, and many of you will have seen the charts of hospitalisations and mortality from COVID-19, which very unfortunately shows a very steep socioeconomic gradient in its patterning. So as one general practitioner working in the deep end says, the legacy of this, the unemployment, the deprivation, that's just going to get worse for patients, because as with all of these things, our communities are going to be hit hardest going forwards. They're not going to be able to bounce back as others may be able to. So in terms of the wider co-design work, well, what did we find through these interviews? One of the core themes was about the volume of complex patient need. And I'll not read these 2 quotes in detail, but they exemplify this point. The needs were deep and wide-ranging. And as one practitioner said, we've got to be honest and say, how much difference can we make? then it can be disheartening, just thinking I can help one guy and then there's 10,000 of them. And I think there was this element of futility and this feeling of desperation around what can I do and how can I take action to address this. A next key theme was around the burden of mental ill health and how that permeated through everything and all activities and networks within the deep end. And as this quote says, we see this all the time, patients who end up on an absolute cocktail of pain meds and psychiatric meds and the rest of it for really quite shaky indications. And my fear is we end up doing more harm by trying to help. But also this quote goes on to say, well, really above and beyond pills, we're quite limited, and what we have that's accessible and acceptable as an alternative for this. And so this is a key problem that was identified as a key challenge for the deep end. Recruitment and retention, no surprises here that this came out loud and clear, but this really was something that stood out as being really difficult and challenging in the deep end, and really something that practitioners were looking for the deep end network perhaps to provide support and look to see whether we could do something around this to tackle that inverse care law that's been spoken about by Samina and others. And finally, there was a theme around the wider healthcare system failing to really recognise these challenges. And Edward touched on this around the funding allocation and whether that adequately addresses the burden of need in these areas. But really the feeling that quite often deep end practices were red flagged or were seen as an outlier or seen as a problem because they had high prescribing rates or they were low on certain preventative interventions. And it was seen that maybe it wasn't always recognised the challenges that were involved. And as we've said, the resource not necessarily commensurate with the need. And so it was this feeling that deep end practitioners didn't always feel that their needs and their priorities and their challenges were well understood by that wider system. So what can deep end do and why do we need it? Well, as I've said, part of what people were talking about was how perhaps it could help to overcome the challenges. But there was also this just thought that maybe it's just a little ray of hope that something might change. So there was the idea that actually giving an identity to blanket areas, practitioners serving areas of blanket deprivation, that having that recognition and that identity would be a force for good in its own right. And the feeling that having this network will be an opportunity to change the narrative and consensus around how important it is to consider the inverse care law and inequalities gradients in everything that we do. So as I've said, this co-design work was really fundamental to our deep end because it's ensured that all the priorities that we've taken forward as a deep end network have been really informed and embedded in the needs and priorities of the network. So as you'll see reflected in the pilot projects that are now taking place in deep end, we have an embedded clinical psychologist pilot that's going on, which is also being evaluated through NIHR funded evaluation of this pilot, and that's really around that mental health burden need. Another one on opioid prescribing reduction, and again things on workforce such as the early career trailblazer. And as I've also mentioned at the start, the North of England Care Support System NECS are leading the use of data to identify and support advocacy for system change and working to profile where research is being undertaken and where we could look to grow that research further and increase research participation in deep end, understanding and noting the challenges that are faced.
So our co-design approach helped us to identify the key objectives that we aligned to the WEIR acronym, and this was coined by the Yorkshire and Humber Deep End GP Network, but which we adopted because it seemed to fit our key themes and also pays homage to our region. And these themes, workforce, education, advocacy and research, are all the pillars that we work towards when we try to engage with the network, which we've been doing through a series of webinars where we invite all of the practices to attend and talk about various projects and bring opportunities for the innovation and any pilot projects that perhaps the deep end practice may not have had the headspace or the time to have thought about. And so over the last 2 years, we've developed from and built on these objectives with our mission statement And really the backbone of our sort of mission statement and all of our objectives is the infrastructure of our network. So engaging and committing to and investing in program management support, enlisting our GPs and professionals working in the deep end practices to be involved in network meetings and events, and aiming to build a multi-professional community from primary care to work in the deep end network. And then giving a space for them to discuss and innovate while understanding their challenges of working in the deep end, and hoping that this will also enable us to have a structured career pathway through education so that people have got exposure to areas of high deprivation, like it's happened for me, like it's anecdotally happened for quite a lot of other GPs who are working in the deep end, and hopefully build a workforce and improve recruitment and retention, not just among the GPs, but among the other skilled professionals in primary care. And continue to have a strong relationship and connection with research, so that we can continue to evaluate our projects that we do in the deep end and disseminate learning to other practices outside of the deep end network, and also ensure that we encourage deep end practice populations to be involved in research, as we understand that they are quite marginalized often in recruitment. And finally, but absolutely not insignificantly, is advocacy, to continue to advocate loudly for appropriate and equitable resource allocation so that practices can deliver the best care to their patients that they have a right to. So thank you very much for listening. For more information, please visit our website. Please follow our Twitter handle. There are our contact details. Rachel Henwood is our program manager for the Deep End GP network, and can usually answer all questions. But please don't forget to submit your Slido answers as well, because we're really keen to understand what your priorities are too. And please tweet your thoughts today from the hashtag NENC Deep End Summit. Thank you.
Thank you, Samina and Sarah. And remarkably, we're ahead of time, everybody. So I'm going to, again, reiterate Samina's advice there for people to please fill in your Slido questionnaire, which is in the link. Please do put questions for speakers or for the whole panel in the chat. We're actually going to go into our comfort break slightly ahead of schedule. So we are going to close now for about 7 minutes, and we will come back at 10 to 1. So we'll come back at 10 to 1 with our next speaker, who is Dr. David Jones. So 7-minute comfort break. Thank you very much. Okay, folks, so just a couple more minutes before we start the part two. I noticed David's there. You got me out of jail, David. Thank you. You're nice and early. Just while we're waiting for people to wander back, anybody who is there, again, please just have a look at the Slido question. What are the key challenges you face in achieving your priorities? And again, the Slido is accessed through the link that's in the chat box. And do please continue to put your questions in the chat box, and we'll hopefully be having a little bit of extra time for questions and answers as we come towards the end of part two. So just a couple more minutes now before we start part two. Okay, so we're getting ready for part two now. We've got a series of talks from people working around the northeast and North Cumbria who are already doing things that are starting to reduce health inequalities. They're quite short and snappy. They're about 10 minutes each. Just a reminder to the speakers, I'll be waggling my finger at you to let you know that you've got 1 minute left as per the briefing. So with no further ado, we're going to kick off, and delighted to introduce David Jones, who's the named GP for child safeguarding in Newcastle. Over to you, David.
Okay, great. Thanks very much. I'll try and be snappy and keep people amused and engaged. And I'll watch out for the wagging finger. So thanks very much for that, David. Yes, so as David said, I'm the named GP for child safeguarding in Newcastle, and I'm just going to talk about a project that we've been involved in. And we've called it the Multi-Agency Safeguarding Local Enhanced Service. So there's a bit of background to this, and that is that for many years, GPs did a variety of work, safeguarding work that was unfunded. And many of you may be aware of this controversy, safeguarding reports in particular for child conferences. There was various debate over a long period of time about how this should be resourced. It's not in the GMS contract. The BMA and LMC were very vocal in trying to say someone should fund this work. And indeed, in 2014, NHS England directed CCGs to come up with a funding solution. And at that time, I worked for the CCG. I had a role as the named GP, which I've retained now. And we need to try and understand how we were going to do it. And people explored different ways. Some people said, we'll just pay per report for the work that's done. But we recognised that there was a whole load of multi-agency safeguarding work that GPs did that wasn't funded. It wasn't just about the reports themselves. Some people looked at having a report writing service, paying some other body to be involved in trying to do it. And again, that had pros and cons. When we looked at it, we got a very clear message from commissioners. This is how much resource you have to provide a LES, which would be a single payment per year to encompass all that work. The challenge then was to try and say, well, if we're going to do it that way, and that's the least bureaucratic, easiest way to do it, how do we ensure that people who do most of the safeguarding work receive a bigger piece of the pie? And that was the challenge we had around developing the LES. So in the absence of reliable safeguarding activity data, deprivation was used as the proxy best indicator. And of course, for those of us working in a variety of practice, I'm sure we will recognise that in some of the most deprived communities have some of the greatest safeguarding challenges. So it seemed absolutely appropriate that would be the best, as I say, proxy indicator to indicate the likely workload for different practices. So by using that, we then identified practices through the deciles 1 to 8, and then we did some financial modelling to try and work out how we could skew the payments, recognising the increased work for practices working in some of those most deprived communities. We also recognised, of course, at the same time that we need to ensure that every practice had something for their work. So it wasn't that practices who had very low workloads received practically no resource, because it needed to recognise that everyone had some safeguarding responsibilities. I'll show you the weighting chart in a second, but in the end, it seemed to be when we played around with the numbers that we developed a financial weighting system that meant that the practices in the most deprived areas received 2.67, sounds quite precise, doesn't it? Times as much resource in the least deprived. I think there was an argument for saying that wasn't really generous enough, recognising the extra workload, but nevertheless, it was a starting point for the work that we did. This graph really just shows how we tried to weight things. We recognised that everyone needed a flat rate, a certain amount to engage in safeguarding processes, and then we worked out, well, if we increase it by a little bit each time, what will that mean? If we increase the weighting exponentially, what will that mean? And in the end, we agreed that everyone had a flat rate, everyone had a certain amount, £500, and then we increased the weighting exponentially, and that got us to that 2.67 increase for the most deprived communities. These are all the practices in our CCG, and you can see we ranked them here across the deciles, and we worked out from there roughly how much each practice would get. And it was very much a finger in the air activity, really, just to try and see. And we tested ourselves, what would that practice get? How will they feel about that? How well received will that be? But also, how much resource are we giving to practices in the most deprived communities, as I say, recognising the extra work they have from a safeguarding perspective. So we did that. It was the multi-agency safeguarding LES. It covered not just reports, but any sort of multi-agency activity you might get involved in. You might get involved in a domestic homicide review and be asked to speak to people or attend a meeting or something. It was really to try and encompass all that work. We did a self-reported practice activity audit. This was very much a bit of bean counting, really to try and satisfy commissioners who asked us, what have you done with all that money? Can you show us some evidence of sort of outcomes? And when we looked at it, it certainly seemed to be that practices were engaged in it, practices were producing reports. So I've just skipped a second there. Slide just changed a second. And that it was a cost-effective model. It seemed to be a good way of channeling resource into the most deprived communities without creating a huge administrative burden, which there would have been if we were paying per report, and at the same time satisfied commissioners in that they knew there was a fixed amount of resource and that it wasn't going to become something that was unpredictable, which is obviously for people who are trying to fund things a bit of a nightmare. So the multi-agency safeguarding LES is something that is now being considered along with all the other local enhanced services by the ICB. And of course, one of the challenges or advantages, I don't know, of the ICB is that they can look across all the different former CCG areas, try and work out what they wish to adopt of any of the LESs that are currently in existence. I guess our position on this is that there is a very clear direction that safeguarding activity and practice should be resourced. That's come from NHS England, and it's really for commissioners to try and work out a means of doing it. We feel that when we looked at it, for example, the amount of resource that would be required to run the LES was about a third of what it would be for a per report model, both in terms of the costs of the activity, but also all the administration that would run around that. And at the same time, by tweaking the model, we could ensure that, as I say, that the funding was skewed towards the most deprived areas, recognising that they face the biggest safeguarding challenges. So whether the ICB wish to adopt this across our area or whether they have other ideas, we're not so sure. But we felt it was a way of pragmatically ensuring patients and practices working in the most deprived areas had the most funding for the work that they do. Thank you very much. That concludes my presentation. Should I pass it back to you, David?
Yeah, thank you, David. That was really, really helpful and a really excellent example of equity over equality. I'm going to hand straight over now to Peter and Jessica, who are the executive GP partners down in Linthorpe Surgery, and they're going to be talking about some of the things that they've implemented in their practice, which is a deep end practice, to tackle health inequalities. So Peter and Jessica, over to you, and delighted to see you both.
Many thanks, David, and thank you for inviting us to present. Jess and I both work at Linthorpe Surgery in Middlesbrough. We're in a PCN of 5 practices, 3 of which are identified as deep end practices. Jess is going to do the majority, the bulk of this presentation. I'm just going to give just a minute and a half, just of a bit of background. As I say, we're part of the Deep End network. Of the 365 practices in our ICB, we've already heard about 38 of them are in the Deep End. The first 30 practices in the Deep End, those populations with living in the most deprived areas, of those first 30 practices, half of them are actually in Middlesbrough. And Edwin mentioned earlier that the Core 20 indicator, so half of the population in Middlesbrough live in the 20% of most deprived areas in our country. So we want to share some of the work that we've been doing in our practice and across the PCN. And I think the title here is interesting: Interventions Implemented by a Deep End Practice to Tackle Inequalities. I've thought about this, and I'm just wondering whether actually the title is more along the lines of opportunities to reshape primary care to support people living in the most disadvantaged areas. And the catalyst, I think, certainly over the last couple of years, has primarily been one of funding. And we've just taken the opportunity of using the funding that's come through PCNs to see what we can do. And I know there's a really important discussion going on in the background nationally around the inequitable allocation of resources in primary care. And part of that is the allocation of PCN funding as well. But this additional resource has certainly been a major catalyst for the things that we can now do. And I would suggest that with more funding and therefore staff, we could actually do a lot more. And finally, before I hand over to Jess, I think what is interesting is that the 2 key roles that I think which have helped us most in supporting people living in the most disadvantaged areas have actually been non-clinical roles. Now, please don't shoot me down. I think we need more clinicians and more GPs. But it's interesting in terms of the work that Jess will just go into a little bit more detail. Have been non-clinical roles, and namely our care coordinator team and our social prescribing link worker team, who've been able to work in different ways. We've been able to use population health management approaches and also link with the wider colleagues in our area. So I'm going to hand over to Jess, who will take us through some of the work that we've been doing.
That's brilliant. Thanks, Pete, and fantastic to see so many people here today. So as Pete mentioned, I'm going to try and talk about some of the interventions that we've put in place. I've got about 8 minutes, so what I'm going to do is just pick a few out here, because actually there are some common themes and learning that we've gained by trying these different interventions. And as you'll be able to see from the slide, there are a few which are perhaps newer or new suggestions, and then some which are in line with contracts, i.e. services that we're already providing. So if I start off with the welfare worker, so we have a welfare worker from the council who we have engaged to work with us in practice. And we've had some really great results from this when we're thinking about inequalities and poverty. So we have a welfare worker who has access, therefore, to both adult social care data, but because they're with us, they also have access to medical data. To give you an overview, in 21-22, they had 109 referrals from our practice, and around 56 of those were for PIP, 25 were for limited capacity to work. Now, with this easy access to data and this access to useful data, she has had a success at appeal of over 90%. And also we've noticed that it's opened up more holistic support. So she works alongside the link workers and also the clinicians where relevant to make sure that these patients have access. What I'm going to do is just give a case study for the welfare worker to try and put it into context. So I've got a patient, Mr. A, who was referred to our welfare worker when they asked the GP for help with an evidence for an appeal. And we know that anecdotally, these letters that we're asked to write often don't really hold much weight in the appeal. And that's often because we don't have enough information or answer the right questions. So the mother of this patient had completed the PIP form in 2019. Patient had attended for an assessment and was awarded 0 points and turned down for benefits. He lived at home due to mental health problems, but the home wasn't actually suitable for the physical problems that he had. It became clear once the welfare worker started looking into the assessment that actually the form had been poorly completed. She then worked on putting an appeal bundle together, which actually comprised over 300 pages. At the tribunal, this gentleman was awarded enhanced daily living and mobility. This was backdated to 2019, so he had a one-off payment of £20,000 and an additional weekly income of £152. This then enabled him to move into his own property at one level. His mental health was improving, and he's also had support, as I mentioned, from additional workers at the practice, and he's working towards returning to employment. So I just thought this was a really brilliant example of a non-medicalised intervention that clearly is going to have benefit for the wider community, for this patient and his family, and actually give back to the community in terms of going back into employment and perhaps not needing to visit the GP as much because mental and physical health have been improved. Next thing, I'll move on to digital inclusion programmes. So we've collaborated with a local charity called the Hope Foundation. Now, during COVID, it was both highlighted and intensified the health inequalities that are associated with digital exclusion. And it's a little bit chicken and egg. We know the people who are digitally excluded have the same characteristics that make people then suffer with health inequalities and healthcare inequalities. There's a big push to digitalise not both healthcare, but a lot of other services, so access to housing, employment and benefits. And we know that there's national evidence and there's also anecdotal evidence, but we don't actually have that much local on the ground evidence and data. So we decided that we wanted to collect that ourselves. So we've put together a survey and alongside this, a number of interventions for both staff and patients. And one of the things about this in particular is that one of the themes across the board is we're trying to learn as we go. So we'll put in an intervention and then we'll look at, what worked, what didn't, how did patients respond to that, to really decide what services are going to be useful to tackle these inequalities. So far we've had nearly 4,000 surveys completed. And these have been both proactive, so targeting specific groups. So, for example, people on repeat prescriptions who don't have access to online services, but also opportunistically, so just across the PCN sending this out. We're currently analysing the data, and there's some really interesting data in terms of specific demographics that are more or less affected, and barriers that people are reporting. But again, I just wanted to give some examples of interventions to try and put this kind of in context. So we have a tea and technology session. We had a husband and wife who attended to gain access to the NHS app, and this was after they'd completed this digital survey. Following gaining access to the NHS app, where they can look at results and communicate with the surgery, they then return for further sessions to gain support on how to access emails and how to use their smartphone. So again, thinking about those kind of wider social determinants of health and keeping people happy and healthy out there in the community. A few other examples, we had a tablet loan to a patient from the device library and a free Vodafone SIM, which meant that they could then search for jobs and attend online interviews. And a referral to English classes via the Hope Foundation. And again, we know that English is a second language, and practices who have a high number of refugees have higher levels of health inequalities and challenges around meeting their needs. Also, we put on a digital inclusion day. So at one of our local churches, we came together with our care coordinators, social prescribers, and a number of voluntary services to provide an invitation digital inclusion day where all of the team were there to provide support and carry out interventions. We had some really fantastic outcomes, and it was also a great opportunity to develop the relationships that we've been building in other forums with our community teams. But what was interesting is we had quite a few people who said that they would attend and they didn't. So we're currently in the process of actually finding out why, because we need to know to then be able to put further interventions in place. And that leads me on to just referencing the 18 to 25 health inequalities programme. So we'd started to explore, I'm just going to get a drink, sorry. Talking too quickly. We started to explore the 18 to 25 group because we knew from feedback on the ground that this group were not attending social prescribing or group support, so offers that we were putting out there. But we also know that we had high levels of mental ill health and high levels of unemployment in this group. And it links back to that comment around people not attending. So what we've had a look at is going out into the community, speaking to patients and residents, but also local providers to say, you know, where are we going wrong here? What is the need? And a lot of the feedback that we've had is actually some of the concerns are around the development of trust for this group, the ability to develop emotional language and for them to be able to articulate themselves. And actually referencing back to bullying at school and a lack of friends and friendship skills. So I suppose I've raised this because what this learning so far has showed us is that actually it's not an A to B. We need to reconsider the way that we're framing our interventions and thinking about the KPIs that we set. So what we've actually started talking about for this age group is a non-offer. And it's quite hard in the context of healthcare provision to think about the non-offer because it's much less tangible. But developing the correct environment for these patients to come along at a time that suits them to develop that trust and those skills that they need, with the hope that they can then go on and look at the social determinants of health within that. So I suppose if we think about the 5 whys of a significant event or a significant event analysis, what I'm saying here is that we start with the last why and not the first when we're thinking about provision for these groups. The final one I want to talk about on this slide is learning disabilities. So I referenced earlier that we were looking at these approaches both within the services that we already provide as well as some newer services. So what we've done with the learning disability reviews is try to improve the way that we provide these and be a bit more holistic in the way that we do it. So as Pete mentioned, care coordinators have been really central to a lot of these interventions. We've worked with Stomp to try and improve the way that we book appointments. So the care coordinators contact the patients and their carers. They send out pictures of everybody that will be there on the day and discuss how you can attend and what will be happening on the day. Those same pictures are on the doors of the consulting rooms and the care coordinators are at the practice to greet the patients. We have one site for our learning disability reviews, and on the day we have everybody that may need to be involved. So we have a doctor, we have a nurse who can carry out any of the immunisations, screening or monitoring tests that we need to do. We also have social prescribers, carers together, and the CHUV learning disability representatives in our coffee room so that the patient and their carers can have an informal conversation and just be in a bit more of a comfortable position while getting everything done that they need in a way that they can access the service. And actually, we've had some fantastic feedback from both patients and carers about that. I can see Dave's maybe waggling a finger. 3 minutes, brilliant. Okay, so I'm sorry to whiz so quickly through those, but I just wanted to try and touch upon a few of those examples, really to to reference the themes and the learning that we've gained. So we have been trying to develop collaborative work with local voluntary organisations and take an asset-based approach to try and really develop the services that we offer both inside and outside of the GP practice. We've been utilising public health data sets, but also trying to develop our own on a local and neighbourhood level. And we have been trying to be quite dynamic in terms of developing an intervention, listening to what people are telling us, and then accepting halfway through that actually perhaps this way or that is not working, and we need to change the way that we're doing things. So the majority of our projects, as you can probably see, have quite a common approach. We've got a common team, so we have a multidisciplinary team, which is really, as we mentioned, clinical support, care coordinator, social prescriber, and voluntary services within the community. And that development of those working relationships then enables us to put in more interventions and actually to gain that continual on the ground information and feedback from our communities. I think at that point I'll probably stop because everything else is on the slide and I've been talking quite a bit, but very happy, as we said, to take any feedback.
Thank you, Peter and Jess. That was awesome. I'm really interesting framing in terms of reshape primary care, and fantastic to hear how the movement of putting people in the centre of what you're doing, moving away from rhetoric and actually doing it is fantastic. And thank you for sharing all of that. Just remind people that that David, Jones, Peter and Jess will be joining us on our question and answer panel in about 20 minutes time. So if you do have questions, do please pop them in the chat box. If they are specifically for a speaker, do let us know that and we'll do our best to try and work our way through them. I'm going to hand it back over to Guy, who's going to be talking to us about waste wellness in Newcastle West. Over to you, Guy.
Thank you very much, Dave. Has the slide moved forward? It has now, hasn't it? Okay.
Yes, it has, yeah.
Excellent. So Peter and Jess, that was absolutely fantastic. Do you register people who live in Newcastle to your surgery? Because I'd love to join. Really amazing stuff that you're doing down there, and I'm sure you will have lots of questions in the panel shortly. I mentioned that I've been a GP at the deep end for 30 odd years, but I'm presenting to you the Ways to Wellness project and the Ways to Wellness charity that started about 8 years ago in the west of Newcastle. And it's essentially talking about social prescribing. It was originally a social prescribing intervention to do with supporting people with long-term conditions, which I'd tell you a bit about. But in this context, it is essentially social prescribing as a useful tool in tackling the inequalities that our communities are experiencing. It's not universally effective, I don't think, but it has potential, and I think the Ways to Wellness project that I'm going to describe hopefully will give you a flavour of that. My involvement was I was a commissioner when Ways to Wellness was set up, worked very closely with Ways to Wellness through the 7-8 years of the contract that's been running, and I now sit on the board and chair the board for Ways to Wellness as I've retired or stepped back from my general practice work. So very briefly, what was the long-term condition project for Ways to Wellness? It started in 2015, and the idea was if we could provide on a universal basis an opportunity for people living with long-term conditions in the west of Newcastle. We were Newcastle West CCG at the time. Would we be able to show that it produced population benefits that the commissioners might well want to continue to purchase? Essentially, that was what we were attempting to demonstrate. And in order to do that, we created from 18 practices in Newcastle West CCG at the time, a cohort of 14,000 people living with the most common long-term conditions that we know all about: diabetes, heart disease, respiratory conditions, and so on. And we also at the same time created a comparator cohort from the rest of the city of Newcastle, from the other CCG in Newcastle at the time, in the early days. And we ended up with a comparator cohort of 11,000 people, appropriately matched for age and for deprivation, compared to the 14,000 in the intervention cohort. And over the course of 7 years, about 9,000 individuals from that intervention cohort have had a social prescribing offer, and been able to begin to engage with social prescribing to support them in their needs. We managed to produce some really significant outcomes. We managed to show that on a population level, comparing these two cohorts, there started within a couple of years, after a couple of years of working very hard to engage with practices and to engage with the populations, we were able to show that there was a divergence in their use of hospital resources. And the hospital resources were measured from the usual mechanisms that CCGs use, SUS data and so on. And we measured every intervention that had a cost to it in terms of hospital activity, whether that was emergency admissions, outpatient attendances, planned interventions, and A&E attendances, and so on. And that divergence went from being very equivalent across the two cohorts when we originally started, to about 10% divergence between the intervention cohort using hospitals, 10% less in terms of activity and in terms of cost than the control cohort, which gradually grew throughout the course of the 7 years. The pandemic obviously produced all sorts of unexpected and difficult to control measures, but that was the underlying trend, and that has persisted. In addition, we've had this intervention studied by Newcastle University and Durham University, a team led by Professor Suzanne Moffat, looking at all sorts of different aspects of the intervention. And they've also been able to measure, looking at the diabetic subgroup, we've had, sorry about the dog, we've had a significant impact at a population level on HbA1c, with a significant reduction in the average HbA1c of 14,000 people in the west of Newcastle. I just want to tell you a little bit about how people are engaged in the process, and a large part of the engagement that is delivered by two not-for-profit organisations, First Contact Clinical and Mental Health Concern. They use something called the Outcome Star, which comes from Triangle Consulting, and this is a self-reported measure on 8 different criteria, and you can see the kind of things that people are asked to rate in terms of the scale, from I'm not thinking about this issue at all through to things are as good as they can possibly be. And you'll see, I don't know, I hope you can see around the star the kind of things that people are asked to think about. Down the bottom we have money, where you live, and so on, round to other things like controlling symptoms or feeling positive. So a very broad ranging and quite holistic star that people are asked to complete every 6 months. And I'll show you the kind of things that people reported. hopefully you've got this large enough, but you'll see that the 8 points on the star are described in these bar charts now, and you can get a flavour for the kind of things that people did relatively at baseline, did relatively worse at, or relatively better at. So if you see the shape, thanks, 3 minutes, if you can see the shape of what we've got there, you'll see that when people showed improvements, the shape is extremely similar to the, say, if you took the orange and purple on the top scale, that's where they started, and you can see that the lower they scored on average for one of these questions, the more opportunity they had to improve. So I think that marks out a fact that there was a personalized response for people that was working for them in ways that were really valuable. But if social prescribing is able to address people's needs, led very much from the individual's point of view in the first place, what does social prescribing still need to consider if we are to really address people's health inequalities? And what the qualitative work on a lot of the study was able to demonstrate was stuff that has been well known for a long time. Thanks, Dave. Just finishing off now. There was a pressure on the social prescribing link workers to engage with as many people as possible, which meant that they had to work fast with people, even though they were able to work with them for a long period of time. And I think there was definitely a degree of anxiety amongst the workers that was picked up from the qualitative research. They felt that when they were able to offer intense and responsive support, they had better outcomes than when they felt that they were being encouraged to engage in greater numbers of people because of the demands of the contract to engage with as many people as possible with long-term conditions. And that pressure, I think, reflects what we know, which is in order to really engage well with a population, you do have to have that proportionate universal response. And even within a project like Ways to Wellness, it was sometimes difficult for the workers to be able to do that. So I'm going to just finish there by saying one more thing. These are some of the research articles on that slide that may be of interest to you if you want to have a look, specifically relating to inequalities. One of the things in the chat earlier was describing how, or I think one of the quotes that we saw earlier that I think Samina and Sarah showed was this idea that you work with an individual and you support them, but there are 10,000 more suffering in the background, and it can feel overwhelming. I think it's really important for us to remember that every interaction we have at an individual level involves validating that individual in ways that are important. And I think social prescribing link workers do that all the time. So that's where I'm going to leave it and hand on to the next one.
Thanks, Guy. And again, another great example of a person-centered intervention. Really interesting for you to note it's so important about what we measure, isn't it, and how we judge outcomes. And I think that was something that Jess and Peter talked about as well. I'm going to hand over now to Laura Cassidy, who Laura is the Network Delivery Manager for the North East and North Cumbria Child Health and Wellbeing Network. And I think, Laura, you're going to be talking to us today about some work that started in one place and it's gone somewhere else. Over to you, Laura.
I've just noticed that the slides have actually disappeared, so I haven't been able to take control.
If you just bear with me 1 second, they're just really
No
low.
problem.
Can you start us off without your slides, Laura?
I can,
Perhaps
yeah, no
introducing
problem.
yourself.
Hi, yeah, my name is Laura Cassidy. I'm the Network Delivery Manager for the Child Health Wellbeing Network, as David just said there, and I'm going to be giving you a presentation on a piece of work that was funded by the Child Health and Wellbeing Network around children's social prescribing. The title of this presentation is the replication of Zone West to Zone Borough, which is a children's social prescriber model by North East Wellbeing, and the role of the network within that, and really just a bit of context around the Child Health and Wellbeing Network and our role in that replication, and how we are learning from that to date, and kind of sharing in the understanding of the model itself. So from a perspective of the Child Health and Wellbeing Network, the network covers the North East North Cumbria ICS footprint, and the network was established in 2018, and it was very much established with involvement from over 350 professionals, children, young people across the region, really to understand what would be the expectation and the ask of the network within our role across the ICS. And it was very much driven by kind of the understanding need and understanding what the ask of the professionals and children and young people would be. So the network from that established the vision, and actually the vision is very much that we believe all children and young people should be given the opportunity to flourish and reach their full potential and be advantaged by organisations working together. And actually, when we asked what people wanted from the network, it was very much around sharing good practice, driving forward good practice and innovation, and actually connecting experts and groups together. And I think the replication of Zone West into Zone Borough is a really good example of a sharing a model of good practice. As I mentioned, we cover the whole of the North East North Cumbria, and we very much work on a lot of multiple projects running at different times, and really sharing that learning and understanding with the wider experts and professionals and organisations. We have a network where we have 1,600 members, and we use that as a mechanism to obviously share information, share good practice, but also I guess we use that to host what we call huddle events, which really gives that kind of opportunity for experts and professionals to come together and share projects and programmes of work and the outcomes of them. As a network, we have 10 priority areas, which were brought by members and also brought by those events in the initial stages with children, young people and families, and they gave us those areas what they wanted us to focus on. So that's the voice of children, young people and families, mental health, poverty, additional needs and vulnerability, inequalities and access, strong start in life, health promotion, family support, childhood illness, data and digital and communication. I think it's important, as a result of COVID, we revisited those priorities, and actually family support was the additional priority added. And I guess obviously from a social prescribing project and programme of work, that family support is kind of pivotal to obviously that child-centred approach. I'm just, thank you, I've just got my slides back up. I can take control. So Zone Borough in Middlesbrough, as I mentioned, was actually born out of the Zone West model, which was developed by North East Wellbeing. And what the idea of the concept of this was that Zone West was actually a model of good practice, which was shown really positive outcomes for children and young people, and the network funded through our Children Young People Centre integration workstream funding this model to be replicated into Middlesbrough. Obviously, Middlesbrough was chosen because of the high level of inequalities and the poor health outcomes, which you've obviously heard about from Dr. Hollingsworth and Linthorpe surgery. So we know that obviously that area was an area that we wanted to prioritise with the replication of this model. And the model as well, I think is really important to say that it's very child-centred focused, very child-centred driven, and it's very much around working with the child aged 7 to 11 years. But actually the focus with this model as well is that it brings together education and healthcare settings. So it's about collaborative parallel work and developing and integrating within local environment to be able to provide the best suite of interventions for children. So it's very much driven by the needs of that young person, and the plans are very much developed in with that young person around what their goals are and what they want to achieve. It's an early intervention approach, so it's very much before child reaches thresholds for whether that's mental health services. It's about ensuring that they don't end up needing those services and really trying to do early intervention. It's very much about driven as well around how long they work for the child is based on that child's needs, and I think that's the really important part when we talk about social prescribing for children, that actually a lot of the time what we're guilty of when we commission services is that they can be 8 to 10 weeks, and actually what social prescribing is different in the way that it works is that children and young people work until they've met their goals and actually their outcomes that are required as a service. It's also about, as we develop the model at place, is that we need to develop those relationships and trust in the local place-based area, and actually that buy into the model, because actually what's pivotal is that actually that local services see the value of the model, and actually as a way forward. I think Guy mentioned in his presentation actually some of the research outcomes is that kind of sustainability around commissioning at a place level as well, and that ongoing commissioning of a service. And it's also about personalising and population-based interventions and embedding into the whole system working with the child centre. And I think some of the learning for us as we developed and rolled this out was that it was pivotal to have a steering group involved with organisations locally to be able to get this embedded and actually buy in locally, so that they valued the zone borough approach in relation to it being rolled out. I think one of the things is that from a Zone West perspective, we know, and this slide is obviously quite heavy in relation to showing the outcomes of the approach. So in Newcastle, they've got, it's part of a research programme with Newcastle University, and the Zone Borough model has also been accepted onto that. So there's evidence now starting to come out of the programme to show its impact on children, and actually some of this has been statistically, and I can never say that word, statistically significant in relation to children's social and emotional difficulties. So I think a part of our challenges in the Middlesbrough area is that actually from a commissioning perspective, people want to see outcomes, and actually what we need to be able to show is those outcomes for it to be mainstreamed and to be delivered in that way. So it's quite challenging when actually we obviously look at the short term sometimes, when actually we know it's a further down the line that we start to see those outcomes for children and young people. And I'm getting the 1 minute finger wag, so I better hurry up. Okay. Oh, sorry, I've just jumped past that slide. So I think, so just to really share some of the importance of to date is actually the role of the clinical lead, and actually our clinical lead in PCN and practice is Linthorpe Surgery, who've been in Dr. Jessica Hollinsworth, and I think you can hear from her presentation how their practice and their PCN are very involved in that assets-based approach, thinking very differently and I think that's really important from a primary care perspective about how we kind of look differently to engage with patients and improve health outcomes. Very much establishing those relationships. The host organisation of the link workers, obviously it was pivotal in relation to if we were going to roll out the Zone West model, that actually health North East Wellbeing, and that is their model, that is their approach, they have that ethos, and we're able to share that learning and be able to develop those link workers in that way. But then that also had their challenges in the Middlesbrough area, because they weren't an established voluntary organisation delivering or having facilities, but actually some of that was overcome with the link workers having a base in the school and within primary care, and actually being really looking at the scope and of the overall costing of the programme, because actually there was some elements, I guess, from a network perspective and from a North East Wellbeing perspective we probably underestimated because of those wider context things like you build it, you're hosting, you're on staff on cost and actually the project management and that support. So lots, and some of the other elements were around clinical supervision. So from a mental health perspective, actually in Newcastle, they had CAMS supporting that, but it's a very different model in Tees. So a lot of the voluntary organisations actually buy in their clinical supervision. So that was really just to give you a flavour, I guess, of the model and how it's being replicated. So thank you.
Thank you, Laura, and thank you for battling on through the most challenging of circumstances. You didn't miss a beat, and
thank you.
Yeah, you did a fantastic job. Thank you so much.
Thank you.
Really, really interesting stuff, and really interesting to think about the opportunities and challenges of taking a fantastic project from one part of our area into another part of our area. So really good job. Thank you. Okay, folks, so we've now got time to have some questions and answers. So I think the first thing I'm going to do is invite all of the speakers from the sessions previously to turn on their cameras. And I think we're going to take down the slides. I'm hoping we're going to take down the slides. Okay, so we've now got all of the speakers who've turned on the cameras. If you're not a member of the question and answer panel, could you turn your camera off so that only members of the question and answer panel are visible on the screen? Brilliant. Okay, so we've had lots of questions, and Rachel has been extremely busy in the background curating some of those questions. So Rachel, do you want to start us off? What a question, and perhaps who it's from, if we know, and who it's for, if it's not for the panel in general?
Yes, definitely. So we've had quite a few questions. And firstly, just to note that all questions will be answered. We'll just have to circulate them at a later date, but we'll get through as many as we can now. So there was quite a few questions regarding funding and allocation. So this is just to the panel in general, and it was, how can funding allocation be improved and proportionately channeled towards deep ends?
Okay, do we have a volunteer to kick that answer off? Guy's unmuted.
Oh, I didn't mean to do that, but I'll have a go. I mean, I think Edward alluded to this in his presentation at the start. I do think the ICB understands it has a responsibility in this area to do what it can to appropriately allocate resource where the need is greatest. Now, I think the challenge that we have, the Deep End Network, are clearly advocating for more appropriate weighted funding to the areas of highest need. But I think also we have a duty to try and demonstrate the benefits of improving resources in that way. So it's a challenge not only for the commissioners to consider how could we grow appropriately funding that has a real impact at the deep end. And we know in that WEAR acronym, if you like, that if we can improve workforce more in the deep end than in other areas, then it will be beneficial to the population that are looked after there and so on. So I don't think that there is any easy fix. I don't think the ICB is simply going to go, you've convinced us, here's a shed load of new resource in terms of money, because actually we have to demonstrate that it is beneficial to do so. And to do that, we'll incrementally have to be able to show that we can create new roles, new capacity that has real impacts, particularly on inequalities measures.
Thanks, Guy. I noticed David wants to come in on that, and then and we probably want to move on to another question, if that's okay. David?
Yes, I was just going to say, obviously there would be specific policies and that kind of thing, but actually it's part of a mindset, isn't it? And everything commissioners do and everything they design with providers is to say, what impact will this have on deprivation? How will this tackle inequalities? It's bringing that mindset into every decision that's made, quite apart from making explicit initiatives to tackle inequalities.
Thanks, David. Rachel, I'm conscious that we could talk about funding all afternoon, but we probably want to widen things out. So, Rachel, is there another question from the chat?
There is. So this question is for Jess and Peter, and it's from Charlotte at Talbot Medical. She was very impressed with how much you've managed to develop and achieve, and wondered, what do you think has aided this? She noted, could it be due to the fact that you've got 3 of your PCN practices who are deep end practices? Because she noted that they're the only deep end practice in their PCN, and wondered how they can influence their resource allocation to be sensitive of patients' needs.
Pete? I'm happy to have a start with that. I think what I was perhaps trying to allude to with some of the learning and themes around the interventions is actually, if you break them down, 1, they're all quite similar, and 2, they're all based on a fairly similar approach in terms of the relationships that have been developed. So I think for us, we'd started a social prescribing service quite a few years ago, pre-DES, and that's given us a little bit of an opportunity to start some conversations and relationship building out in the community. That meant that when we started looking at population health management approaches and ideas, we had a set of relationships that were already there in place, and I think for us that's been a real advantage. Pete, I don't know if you've got anything else to add to that.
Yeah, I mean, I think being connected with the deep end, but I think that statistic that I quoted, just having lived in, I mean, I live in the middle of Middlesbrough, and half of the practices being in the deep end, I think you feel it, and you get a sense of, well, this becomes normal, and then on a kind of regular basis, you're kind of reminded of the kind of challenges that we do have. And I'll always be an advocate for more resource. We do need more clinicians. Workforce capacity is a huge issue. Recruitment is a massive issue. Retention is always a challenge, and we've got those same challenges at Linthorpe and our PCN. But I also realise, I think the solutions don't just lie with chucking a whole load more clinicians at the problem, and we've got to reshape the way primary care works. And I think that's probably what I think these projects are a reflection of a mindset of, this is not just about historically, if I can caricature it, 10, 15 years ago, we literally just opened our doors and just waited for whoever came through, with no kind of prioritizing, sort of looking at how we would use our resources in the best way. I think now, with the funding that we've got through PCNs, I think connecting with all the wider stuff in the deep end, we are working differently, and I think the clinicians are looking at the problems differently. They're using the link workers much more strategically. I think referrals are going, through the roof, and there's a heap more things I think we could do in terms of connecting with the wider VCS and partners that would really enable us. And I think that the issue to me is one of resource. I think the ideas are there, and you need enthusiasm. I think Jess has been a great example of that. She's got bags of energy and enthusiasm. So I think leadership is also a key thing to making that happen as well.
Thanks, Peter and Jess. Samina and Sarah want to come in on that?
Yeah, I just wanted to say that I think that one of those issues around being an individual practice and maybe the only deep end practice and having those challenges is part of our role. I think we see that as the deep end network. Part of our role is to help you think about, how do you advocate for that? How do you look at different opportunities to put your voice forward in your PCN, so that you can maybe try and think a bit differently and change that mindset that both Dave and Peter have alluded to.
Dave Martin
Thanks,
raised his
Samina.
hand, but he would like to come in, if that's okay.
Sorry, Martin would?
Yes.
Yeah, no, we'll move on. No, go on, Martin.
Just to say very briefly, I mean, I 100% agree with what Peter and Jess are saying about it not being just a clinician's solution to the problems that we're facing. But there are sort of 2 main groups of deep end practices. There are those larger teaching practices like mine, like Peter's, like Guy's, where recruitment is less of an issue and clinician recruitment is less of an issue. It still remains a challenge. But then there are the big rump of small DPEM practices for whom clinician recruitment is an absolute priority, because they just don't have the clinicians to meet the clinical demand, never mind expanding out to meet some of the far more wide-reaching demands that you've managed to address as a practice. But I agree with the principle, but we've got to recognise the differences.
Thank you all. Rachel, should we have another question?
Yep. This is a question from Ian Miller for Guy. He wonders how matching up to the standards Julian Tudor Hart sets in his quote square with the time limits patients are given with their GP for an appointment.
Very good question. I do blame Julian Tudor Hart for my lifelong challenge of running to time, because not only did he say you need time to be able to address appropriately in that consultation the needs of the person in ways that don't harm them, the way that that quote described. He also wrote about how in one of his books, how the person in front of you deserves your undivided attention. So you may have 6 people sitting in the waiting room, but you cannot let that interfere with what you are attempting to achieve in that co-productive approach within the consultation itself. I read that and I really believed it, and as a result I spent my working life running on a good day 30 minutes behind, on a bad day an hour behind. And what was interesting was that how many people would come in. I'd always apologize profusely if it was over half an hour, and people would say, don't worry about it, I've got time and I know you will give me time one day when I need it. It was almost the stock response. And I think if you read the paper that I mentioned earlier from Iona Heath, Mysteries of General Practice, she also alludes to the fact that actually this contract between us, and it's not just GPs, it is the wider workforce, the workforce in the deep end and the people who use us, is often very forgiving on their part in terms of delays. Of course, it's a challenge. When I started, I think the practice ran 7.5-minute appointments, and we're now up to 15 minutes. And that's never enough either. But at least we are attempting to address appropriately the time needed.
Thanks, Guy. Jess?
Yeah, I think I just wanted to add in that I feel like this question slightly links to the conversation we were having around the GP role in general in terms of patient behaviour and expectation and the way that we support and educate patients. So yes, the GP has that role, but as you mentioned, Guy, it's the wider workforce as well as the GP, and there's certainly some work to do around expectation. I know from some of our feedback from digital inclusion, for example, or looking at some of the barriers to care navigation, often the responses are only a GP can sort that out, or I need to be seen face to face, or I want a response in this manner, or the expectation is X. And actually sometimes that kind of behaviour pattern and expectation is a barrier to access. So we perhaps need to do some work on that. And these are behaviours that we as a kind of healthcare provider have perhaps allowed for over the years, and we need to start thinking about that differently to support patients, really.
Thanks, Jess. There's a really strong theme coming through here, isn't there, about mindset and seeing the issue differently so that we see the solution in a different frame. Rachel, should we move on to a different question?
Yes, so we've got an interesting question here. Is there a risk that a focus on healthcare inequalities may widen the inequalities gap by never truly addressing the wider determinants with health?
That is an interesting question. Who'd like to take us, start us off on that one? Samina and Sarah. Not sure whether it's Samina or Sarah.
So I think what we would say to that one is that healthcare inequalities are part of a wider package as we work as a health system around how we address health inequalities. And the key there is about that partnership and the systems working. So addressing healthcare inequalities through what can be done. Edward pointed to the Core 20+5 agenda, and the work that's done with all of our wider partners is really important. So we all need to play our role, but understanding that the frameworks for how you address inequalities in health and healthcare are wider than that we all need to work together in a systems way. And I think that's why events such as today, with the broad audience that we have here, are really critical, because we all have our part to play in our own bit that we have as part of the system. So I think the key thing that the evidence shows us is the things that we can do to address health inequalities, and the things that we can all do to address healthcare inequalities. And it's around understanding that evidence base, understanding our locus of focus of control and what we can do in our working world to make a difference, and how we all collectively together as a system work to address the wider health inequalities that exist across our system.
Thank you, Sarah. And Edward?
Yeah, thanks. And just to build up on Sarah's response there, I think there's a risk the other way around, that we fail to acknowledge the inequalities in access, in experience and outcomes, and we focus on social determinants. I think there are things that we can do within healthcare that can narrow the gaps. But yeah, I don't think it's an either or. I think we need to do both, and again, be respectful of the different parts of the system and the roles that they play, so that we are maximizing on the role of the broader system. So local government, the role of private sector, the role of local communities, and then we are very explicit on the unique role that the NHS needs to play in terms of the healthcare inequality. So I think it's doing both. It's not an either or.
Thanks, Edward. I've got Jess and then Peter, and then I think that's probably all we have time for, because I can see Becky has joined us, who's our next speaker. So Jess?
Yeah, just two really quick points. So I think one of them is, I feel like this links to some of the funding conversations with the thoughts around what are the outcomes and KPIs that are attached to funding in terms of the freedom that we have to make interventions and deliver interventions. And then yeah, sorry, forgotten my next point, so I'll hand over to Pete, and I'm sure I'll remember it in a second. Oh no, that was it. Sorry, just to go back to there's a social prescribing service down in London, and their big tag is don't medicalise, socialise. And I think it's really having the conversations, like Edward said, around what is our role as a GP, what can we target within the practice, and actually what is outside of the practice that we need to work with and alongside. Thanks.
Thanks, Jess. And Peter?
20 seconds. I'm probably just going to replicate it. I think we're at risk of really losing enthusiasm if we're trying to change things that we can't change, or influence things that are actually beyond our control. So I think that Sarah's point was brilliant, that locus of control. And I think what would really help as an ICB is to get that evidence off the shelf of the things that we can do locally and at practice level, and really support practices to be doing that, cognizant that the biggest stuff is outside of our control. So I don't have a problem with healthcare inequalities. That's probably more appropriate, because the biggest stuff is beyond the health system, as we all know. And I think the debate is really to try and shift that to the wider system around the socioeconomic problems in education and employment and so on. But I'll leave it there. But thank you. Really good point, Sarah.
Thanks, Peter, and thank you to all of the panel. My sense is we could have continued much longer in this part of the conference, but unfortunately we don't have time. So we will, as Rachel said, endeavour to address everybody's questions that have been raised, and we will figure out a way of doing that. So I'm going to invite the panel to turn off their cameras now, and so we'll be left with just myself and Becky. And I'm going to hand over to Becky James, who is going to talk to us about the Health Inequalities Primary Care Toolkit development. Over to you, Becky.
Brilliant, thank you. I don't think I can control the slides for some reason, so I don't know whether someone else can move them on for me. That would be perfect. It's not giving me the option at my end, so if someone else could move the slides along, that would be great. So thank you very much. Yeah, so I'm Becky James, Health and Wellbeing Programme Manager from the Office for Health Improvement and Disparities, and I have a lead for health inequalities across the region. And I just want to talk briefly about a kind of practical support tool to try and bring some of this work together around how we can sort of address health inequalities across primary care, based on some of the work that we've done already to support foundation trusts in this area. So if we move on to the next slide, please. So just to give a bit of context to where this work has come from, in May 2020, as part of a multi-agency steering group, we did a lot of kind of regional work around health inequalities impact assessment, which really looked in detail around the impact of COVID on health inequalities across the North East. And after I've done my presentation, I'll share the link in the chat to the bigger piece of work. And this kind of really looked at a series of recommendations based on the kind of impact of COVID. And this identified, as part of these recommendations, the need to really kind of turn some of the evidence into practical action, and the need to develop some sector-specific tools to really support partners to sort of take forward some of this work. And one of the things that came out of that was the development of a health inequalities toolkit. And we started off this work, as I said, to support foundation trusts in some of this. So the aim of bringing together a toolkit was to try and sort of funnel down what was really kind of complex issue around health inequalities into a really kind of simple to navigate resource, bringing all the kind of evidence-based tools and resources around health inequalities into one place. And by doing that, kind of supporting a bit of coordinated action around supporting partners to sort of do work around health inequalities, sort of supporting the implementation of lots of different guidance documents that seem to kind of quickly one replaced another, and having a series of kind of key lines of inquiry and prompts, I guess, to recognise that actually there's a lot of work already happening in this space, but it was kind of what could build on that to sort of strengthen some of that approach. And the next slide, please. So this just gives you a bit of a sort of flavour, and again, you know, I can share the link to the full toolkit for Foundation Trust, but this just gives you a bit of a flavour of what that looks like. So very kind of infographic, not text heavy, trying to sort of navigate, like I say, a complex issue into a series of quick guides around sort of information and links to different resources and information, and sort of prompting questions. The next slide, please. And if you've been really paying attention to what we've heard before, you'll have seen this slide already in Edward's presentation. So again, just reiterating this kind of bringing all of the series of different guidance, particularly aimed at NHS organisations that we've kind of seen building up over time, and sort of, like I say, one kind of quickly being replaced by another. And the kind of aim of the toolkit is to sort of replace all of that with some core themes for action to tackle health inequalities, and these are listed on the right hand side there. And the idea is that actually if we work together around implementing action against these 7 core themes, that actually that will then go towards addressing the needs of all of the things that are set out in these different guidance. So the first one is around sort of firstly understanding what inequalities are and what inequalities exist within our kind of patient populations. And then once we kind of have that understanding around that, then how we start to do work to address inequalities in access, use, outcomes and experience. Then looking at sort of opportunities around different prevention programs. We've heard examples of kind of all of these in some of the work that people have presented today. So then how we use those interactions with patients to identify the social determinants of health. This has kind of come through on some of the things that people have identified through the Slido around workforce. So looking after the kind of health and well-being of the workforce, as well as making sure that we recruit and retain a real sort of diverse workforce as well. Loads of opportunities around partnership working, recognising that actually not just one part of the system can tackle health inequalities on its own. So it's how do we kind of maximise those opportunities around working as a whole system across the region, and then that opportunity as an anchor institution, and really kind of maximising the role that different NHS organisations in particular play around things like employment, around sort of environmental issues, and being that kind of responsible sort of organisation. And the next slide, please. And so kind of from a primary care context, I've just sort of tried to pull out some of those key themes and how that might link in a sort of primary care, thank you, in a primary care context. So I'll just sort of leave that up and won't sort of read that out in too much detail, but you can kind of start to see where that might link with some of the kind of primary care priorities, and what some of the things that the toolkit starts to start to look at. And the next slide, please. So what I've tried to do here, next slide please, is pull out how County Durham and Darlington Foundation Trust have applied these themes to look at a health inequality strategy. And I guess this is how the toolkit is useful in terms of, and I've just pulled out just the first two themes. So firstly, understanding inequalities, and then how to address them. So they used themes to develop a health inequality strategy, working with their health inequalities exec lead, and then the public health consultant in the trust, and they kind of used the themes to frame this kind of looking at using the sort of prompting questions within the toolkit to look at what's already currently in place around this first theme around understanding inequalities, then some of the gaps and areas for development, and then some key recommendations based on each of the themes. So if you move on to the next slide, that just shows for the second theme the same thing, and obviously that was built up for each theme, so that allowed them to use those themes to develop a strategy based on bringing those things together. And again, that just kind of shows how it could be used in practice. And then the next slide, please. And then kind of following that and doing that sort of process around looking at kind of what was already working well and identifying areas, that then kind of have developed some key areas of work looking through a health inequalities lens. So this has included a real consideration of inequalities in elective recovery. So this has been through the Waiting Well programme for people waiting for surgery, a review of outpatients who didn't attend using a health inequalities lens, so that, and a development of outpatients dashboard, really using like evaluation and service improvement to identify and address inequalities for diabetes and long COVID outcomes, and then that kind of system-wide working using a population health management approach. So that's just examples of how that kind of approach and those themes have been used to really sort of address health inequalities work in the trust. And the final slide, please. So that's a real kind of run through of the toolkit, and I guess in terms of thinking about how this could work for primary care, I'm happy to sort of support a primary care version and work with stakeholders to develop a version that will be useful and fit for purpose to support work in practice around the themes, and supporting local health inequalities plans. So, happy for people to contact me if you think you'd be interested in this, if it will be relevant. But I think the main thing is that those themes can be taken and used to support work as set out in the trust example. And I think the key thing is that actually by working towards a set of themes, it supports that coordinated action across the system. But please do get in touch if you have any queries, and I'm happy to support that work. Thank you.
Brilliant. Thank you, Becky. And really useful framework, as you say, and you're really keen to hear from people. So people do please reach out to Becky. Okay, so our final speaker for the afternoon is Dr. Martin Weatherhead, who is the co-clinical lead of the North East and North Cumbria Deep End Network, and he's going to be talking to us about some planned next steps for the network. Over to you, Martin.
Thanks, Dave. Thank you, everyone, for still bearing with us. It's been a long meeting. I've really enjoyed it. I've learned a lot of things for me to consider from lots of different perspectives. Oh, I've got control again now, excuse me, and now, but it's not showing me at the bottom how I can move it. Should I stop control?
Yeah, why don't you stop control and we'll keep hold of it?
Yeah.
Okay.
So I've been a deep end GP now for 25 years, and I thought the guy right at the very beginning really eloquently described the real privilege, the unique privilege of working for decades in general practice. And I think that Peter and Jess described the real benefit of knowing your population better and being able to have a positive impact. In my personal reflection is that it's always been challenging in the deep end, but it's always been rewarding. I think that, you know, we need to get the messages out about what we're doing. The audience here are the converted, and we need to try and learn how to preach to the unconverted as well. I think that when I think about today's presentations, and we've heard repeatedly about Core 20+5, we needed to frame ourselves as a deep end network about how we fit into the Core 20+5 agenda. Well, the water at the deep end is always deepest in the deep end. And if we can learn to find ways to deliver interventions which have a positive impact on health inequalities for the bottom decile, that learning can be disseminated through the rest of the bottom quintile. But my other real plea is to say that when we're thinking about Core 20+5, we've got to remember the Core 20 and not just focus on the plus groups. So I thought that the presentations were really brilliant, and you know, the impact of having a positive impact on children and their behaviour in a very early stage, that has an impact on the whole community, on families, on carers, and everything that has been done. We need to widen that. The learning has been fantastic, and we have to work out a way to do it. So our aims and aspirations for the future. How do we improve outcomes for our patients, and how do we support practices to do that? It goes back to the WEAR acronym. And the workforce, we've heard repeatedly, is really important. We've got to improve recruitment to and retention in deep end practices. And that's not just the new innovative roles, which we've heard some of today, but this is about the core staff. We have to work out a way to get people who want to work in the deep end. We need to identify them, we need to enthuse them, and we need to keep them working there. As a deep end network, we are using the education route to think about that, but we're also using our pilots to try and work out different ways of using different staff groups. So the embedded psychologist in primary care is a really interesting response to the self-identified problem of the high prevalence of mental health problems, but really complex mental health problems as well. I just want to really stress that these are paid pilots. These are pilots. So if you're a practice out there and you're interested, we provide the resource for this because we know it's hard to find the resources. We're looking at two different types of embedded psychologists, and we're going to try and compare them to see which one works best. One of them is using the well-established model in St. Anthony's, which is again learning from the good work in a deep end practice elsewhere and trying to disseminate it across the network. They use the employed model, but we found it really hard to recruit to the pilot, so we're looking at a rotated model from the Mental Health Trust as an alternative. We're providing protected time to review opioid and gabapentinoid prescriptions because, again, we know that chronic pain prevalence is much higher in deep end populations, and the challenges of changing prescribing patterns can be more entrenched and difficult. And then the childhood immunisation and audit support is potentially a response, if we can develop it, to some work that's already ongoing in the prevention strand. But we're looking at possibly developing a roving team who can help support practices to address the unmet need of underachievement of immunisation targets. Education often focuses on just telling people how to do things better, and often the impact of that can be negligible. What we really need to do is to find ways of getting those professional groups and targeting them as undergraduates and then through their postgraduate training so that we can get a sustainable workforce who are committed to working in communities with the greatest need. We see lots of pathology in the deep end. It's interesting medicine. It's rewarding. How do we get that message out to everyone else? Part of it is in the fellowship scheme, and as GPs are naturally competitive, I hate to say how good the work is that Linthorpe have done, but they've managed to recruit a deep end fellow. And one of the principles of that pilot was to build on that thing I was talking about earlier, where the deep end teaching practices find it a little bit easier to recruit. So they're buddying up with a smaller practice who find it really difficult to recruit, and using that extra resource, again, partly funded through the deep end, to work out and into the other practice. Next slide, please. I'm going to cover the research part first. I mean, it's been covered a little bit earlier on, but we need to continue to support the deep end research, because that's going to underpin our understanding of what we need to do better and differently for our population. And we need to evaluate what we do, and then we need to see how we can disseminate that to other practices. And we heard today that really good example of how the good work in Zone West was then translated and transplanted into Zone Borough. All the pilots that we're doing will be evaluated, and there'll be evaluations linked to hopefully all of the work that we do. That's one of our fundamental beliefs as a network, that we need to learn from what we do. Next slide, please. Advocacy is always really important, and we need to continue to advocate to push for a resource allocation based on need, the proportionate universalism we've heard about. But we also need to build our links with other deep end networks, which we're doing, because we need a national voice to advocate for changes in funding allocation, resource allocation to nationally. The allocation, as we talked about earlier, is not just about funding. It's less about funding than actually access to the human resource that we need to make a difference when we look after the populations that we look after. We are trying to represent the deep end and the deep end perspective at lots of different ICB meetings, but we need to do more. The overarching ask that we made of the ICS are just outlined there very briefly: investing in primary care, its integration, committing to equitable and proportionately allocated resource, and ensuring all ICS decisions are made on the basis of an equality impact assessment, which explicitly considers deprivation. Next slide, please. But why are we advocating, and what are we advocating for? I think that we need to have more people, more time, and more specific training for people working in socioeconomically challenging environments, because we know that what we got at the minute is less staff, less time to look after more complex patients. Dave Jones's example is one way that you can actually change the allocation of resources, but we then need to find the people who can do that job as well. In the North East and North Cumbria ICS, we have one whole-time equivalent GP per 10,000 patients more in the most affluent decile than in the least affluent decile. But we know that the way that people think about resource is changing, and actually the wind is with us at the minute, which is really encouraging. So we need to expose students early in their career, and we need to do things differently. We know that we must change resource allocation, but we need to go back to thinking about primary care as a hub, but only a hub as part of a huge, complex, interacting network. PCNs are part of the acknowledgement that general practice isn't sitting in isolation, and the examples of some of the practices that you heard today show how it can work in reality. But the PCN model can perpetuate the status quo, and so we need to keep learning. I think that we heard some really interesting examples, and there's a fantastic example from Peterborough where a whole PCN was a deep end PCN, and they understood what the differences in the population were and how to address them. And again, it echoes the learning from the GPs that we heard earlier, and that was that it was not clinicians who made the big difference. That population was mainly English as a second language, and they used a lot of community resources and community resource link workers to help the way that that population accessed healthcare in this country. Next slide, please. So how do we think differently? How do we do that? Well, I think that we need to think about it as in terms of practices and clinicians. We would like our fellow Deep End Network clinicians to think about seeking support from the Deep End community. We'd like to engage the Deep End community, but we need to know what would work for you, and that's why the Slido question was there at the beginning. You know, how do we do things in a way that helps us solve the problems that you face? So we really want to hear your views, and we want to share the learning. We've heard some great examples, but we want to hear your other examples too. For other stakeholders, I think you've got to realise that particularly that time is precious in the Deep End. There aren't enough clinicians. We heard that in some practices there are, but on the whole, there's less clinicians than there are in more affluent areas. And so how do we commission services in a way that don't impact on their ability to deliver their core function? How do we not overwhelm them? If we know that we've got to find a problem and identify what the problem is and have a different solution to that, can we really do that in a practice where thousands of the patients are going to be affected by that intervention? Can you expect that practice to, with their existing resource, to be able to do things differently for thousands of patients? It might be different if there's just a 50 or 70 of them in a more affluent area who need the intervention. So case finding has to come with a caveat that you don't disincentivize practices with the performance metrics that you choose. Part of the way of identifying what the potential impact is not to present data without deprivation stratification. Part of some of the solutions are that all communication should take account of a population's health literacy. What we know is that still we do roll out national screening programs with the same old letters sent to every patient in exactly the same way. We did it with the aortic aneurysm screening. We're about to do it with the targeted lung health checks. What do we have to do differently? In my practice, if we would have missed one of the peak incidence age groups for lung cancer onset if we just look at targeting the lung health checks at the age population that's recommended in the national program. So how do you make a difference there locally? What do we do? How do we do it different? And finally, ensure digital inclusion takes account of socioeconomic exclusion. Again, we heard another project about that earlier, but there's also an example in Sunderland when we set up a technology platform for virtual ward and managing COPD patients at home. What we did was we made sure that the technology that we gave people, the hardware, was enabled so that if they couldn't afford network connectivity, that they could use a phone 4G connectivity, so they could still participate. So technological exclusion on the basis of not being able to afford the internet didn't mean that you couldn't then be part of the project. And right at the very beginning, we wrote into it that what you had to do was make sure that you got an even spread across the postcodes of participants in the project. Next slide, please. So how can you help us get there? So I've already said we know that you're that you're under-resourced, that the workload is really challenging, but we still need your advice on what works for you or what works better for practices, for organisations. But how do we get that advice? Are the webinars? Are the mail shots? The emails? Are they the way? The Twitter? Is there something that we could do differently? How do we become part of what you need us to do? How do we become part of your suggested solution? And then how do we use primary care as a hub without overwhelming its ability to deliver core functions? Questions that we need help to answer. Next slide, please. And how can you support the network? Well, I'd really love it if we could get more of the practice, more clinicians involved in the networks in their local area. We know that what's happening out there is really important and what you're doing is really important. And we want the network to be seen as a support. And we want to build that sense of community amongst the Deep End network practices. For other stakeholders, what can you do to support the Deep End network? How can you help those working in the deep end. How can you help the deep end patients? Because ultimately that's what it's about. There's no point just helping the deep end clinical networks if that wasn't going to have a benefit to deep end patients, the patients who traditionally healthcare is neglected. We know that improving health services just widens inequality because the people who don't go still don't go, and the people who do get better services. So for the other stakeholders, we need you to listen to them, support the needs through the way we allocate and use resources, but understand that the network is also here as a support. It can't solve your problems. It's not the solution to every problem. It's not the solution to core 20 because we're looking after the bottom decile. It's not the solution to all of the inclusion groups or the exclusion groups that we talk about as well, because it's based around socioeconomic exclusion. Next slide, please. So thank you for the opportunity to present the closing remarks before Dave. I thought that there's been a huge amount for us to learn, but there's a huge amount more for us to learn, because what we need to understand is how do we make it more valuable for everybody, for patients, through quality of the clinicians, through the research, through the learning. How do we make it more valuable for the people who work there to feel included in a network which is mutually supported? And then finally, how do we learn from you all? Thank you.
Thank you, Martin. A great closing speech there. Folks, it falls to me really just to start to wrap up. Martin, I think, covered a lot of the key themes for today. One of the things that stood out for me was this issue around mindset and how we start to see the issue and therefore the solution differently. And I'm very struck by Peter's framing of reshaping care. I'm also drawn to a key theme around connection. We are stronger together. Do we have a health problem or do we have a connection problem, is what Cormac Russell asks us. From connection and collaboration grows trust. From trust grows influence. From influence grows the ability to change. And that's clearly what we're all advocating for today. As Marty said, we're continuing to learn, and we need to continue to learn together. To that end, I would draw everyone's attention back to the Slido and the evaluation for today's summit. Please do let us know what you thought, and do take the time to fill in that questionnaire. I'm really going to close, and I know we do have a little bit of time, but I'm going to close by just thanking people. Really, I'd like to thank all the speakers. I thought you did a fantastic job. I think keeping to time over 2.5 hours is really tricky, but you've done a great job. And the way that you rolled with the inevitable technical hitches has been absolutely fantastic. So thank you to that. Thank you to the behind the scenes team who have been putting an awful lot of work in before and during today. And you've done a great job in terms of making things work so smoothly. But most of all, thank you to you for taking the time out of a busy working day to come and to think differently together. And by thinking differently together, by continuing to learn, by continuing to challenge, we will get further. So thank you very much for today. I hope wherever you are going back to, or what you are going back to, it goes well. And please do continue to fill in the evaluation, and we will be in touch through the usual channels with feedback from the questions. Thank you very much, everybody.